box. I think we'll start now. My name is Alpha Chapendama. I'll be your moderator for this session this afternoon. I work as OVC advisor with USAID here in Malawi. I would like to welcome you all to this session, which was created for OVC and clinical colleagues to learn about the strategies used by local partners to cascade HIV services into the community and improve clinical outcomes for children and adolescents living with HIV. 3 local partners from Uganda, Mozambique, and Namibia will share their experiences and offer practical ways to better support children and adolescents living with HIV and their families through case management, differentiated service delivery, and stakeholder collaboration. We are very excited to have you with us in this session today. So before we start, I would like to ask all of you to kindly introduce yourselves in the chat box by stating your name, the organization that you are representing, and the country where you are coming from. The session today will be translated in Portuguese and French, so please kindly take note of that. I would also want to thank Lauren Murphy, who's going to be our note taker today, and Michael Sayer, who's and managing the chat box as well today. So I would like to thank them and really appreciate what they are doing for us. I would also like to say that our 3 panelists from Uganda, Mozambique, and Namibia are going to talk a little bit about the abstracts which they have shared with us. Their presentations, which will be very brief, will be followed by a few questions from myself, and then we'll open for Q&A so that we can hear questions from all of you. But as all this is going on, I would like to encourage you to be putting down your questions in the chat box so that at least we have a record of them and they can be attended to. But after the session, we'll be very happy. After the presentations, we'll be looking forward to hearing your voices as well. And if we don't manage to go through all the questions, since we are taking notes, we'll make sure that the presenters respond to the questions that will not have been attended to, and the responses will be shared with all the participants after the call. And we also hope that after this call, conversations will start happening amongst different colleagues to explore what will have been discussed further. So without taking up much of our time, I really want us to get into our presentations and to start hearing from our panelists. Our first panelist will be from Uganda. It's Caroline Kemigisha. She's going to talk a bit about the abstract which they presented. So Caroline, over to you. Thank you.
Thank you so much, Alpha. Good morning, good afternoon, and good evening to you all. My name is Carol Kemigisha from Uganda. I work with a local partner called TPO Uganda. We implement a USAID funded activity called Keeping Children Healthy and Safe. So I am privileged to present a model that has worked for us to accelerate viral load suppression among children living with HIV that we support on the program in the 17 districts where we work as an activity in central and southwestern Uganda. Next slide. Yeah, so this model, first of all, just to give a brief background about Uganda. So Uganda is a country where we have seen great interventions around HIV prevention and care, and we've also seen that we have progressed in terms of the performance. We moved in terms of viral load suppression We moved from around 36% in 2016 to around 48% in 2019. And currently we are at 88% viral suppression for children between 0 to 19 years. Now, as a program, we realized that when you look at the 95-95-95 cascade, we needed to do something around viral load suppression, especially for children, because when we began this activity in last year, October, December last year, we realized that viral load suppression wasn't doing well. So we thought about a model that will actually help us improve along those lines. Yeah, next slide. Yeah, so we call it the pairing approach. This is a model that, first of all, requires the OVC mechanism or activity to work closely with health facilities and clinical partners. It's a model that, first of all, harnesses on the capabilities of the social workers and the clinical staff and the counselors, as I will be explaining. It's a model where sometimes we involve the local government staff, the community development officers, especially when we are dealing with children that are in households where we have violence against children or where we have gender-based violence. It's a model that calls for conducting joint home visits, where you pair up the OVC community workers and the facility team to be able to offer a comprehensive package of services. And among the services we offer to these children is psychosocial support. We look at response to gender-based violence and issues around child protection. It's a model where we look at adherence support and clinical management, all as a comprehensive package when we conduct these joint visits. Next slide. Yeah, so this is how it is done. First of all, when we came in as an OVC partner, we needed to work closely with the clinical partners and the health facilities. So the first step was for us to sign MOUs with these clinical partners and regional referral hospitals. The technical team at USAID in Uganda actually supported us to come up with a very clear MOU. We also conducted facility entry meetings that kind of opened up the door for us to be able to identify children that need to be supported, but we have also consistently conducted facility engagement meetings. We also identified case workers that we placed at health facilities, and on a monthly basis, we are able to line list children that are non-suppressed that we have on the OVC program. So we conduct intensive adherence counseling at household level, and we are able to identify the suppression barriers. Once we identify the barriers, we categorize them, and we are able to know where we need the support of a facility counselor and where we need the support of the community development officers, especially with issues to do with gender-based violence and violence against children. So we pair up teams with the community parasocial workers and the social workers on the program. We conduct joint visits and offer comprehensive support to the children, and the social workers continuously follow up to ensure that this support trickles down to improvement of the treatment outcomes of these children. As you will see, the results have really been commendable. So yeah, thank you so much. So the results, we started Q1, that was last year in October, December, at 78% viral load suppression for the children. In Q2, it improved to 89%. By end of Q3, we were at 90.3%, and at Q4, we are at 93% performance. So we have been able to achieve this because of the pairing model, because we have been able to offer comprehensive services to these children. So just to quickly mention that as an OVC partner, other than supporting in viral load suppression, it's very important for us to know that as OVC partners, we come in handy when it comes to mobilizing children for index testing. We have continuously supported our beneficiaries to adhere to treatment through home visits that we conduct. We work closely with the PLHIV networks at community level to be able to provide peer support, especially to the clients we have that have disclosure issues. We offer appointment reminders every time we conduct home visits and make sure clients turn up for their clinic appointments. We offer referrals for any other services that we are unable to provide as an OVC partner. And we support children, especially those that live with elderly caregivers, to identify treatment supporters who can be relatives or people nearest to them. We also do conduct gender-based violence screening to be able to identify cases at household level and respond to them. Of course, we continue to provide psychosocial support, which is very important. As the facility does this, we also do this at household level, and we economically empower households to be self-sustaining. And of course, nutrition is one other key intervention we do as an OVC partner. So as I conclude, I want to say that first of all, the move by USAID to make sure that OVC partners work closely with the clinical partners and health facilities is a move in the right direction. And if we can ensure that there's collaboration at partner level, this is something that is commendable and will help us to achieve the 95, 95, 95. Thank you so much. And over to you, Alpha.
Thank you so much, Carol. Thank you so much for a very good presentation. We'll move to Dr. Mangwana. Over to you. Thank you.
Thank you, Alpha. Thank you, everyone. My name is Adrian Mangwana. I'm a Senior Technical Advisor for the OVC program here in Namibia. The name of the program is Namibia Adherence and Retention Program. And it's a USAID funded project. Just to give a background on Namibia, when it comes to the UN's 95-95 goals, Namibia is currently at 90, 98 in Inter-1. And but when we look at the age group 0 to 14, we find that the first 90 is at 80%, the second 90 is at 93, and the third 95 is at 81. So if you see these figures, it shows that there is need for collaboration within the country among all the stakeholders so that we can achieve the 95-95-95 goals among the children. So the goal of this project was really to increase the number of children living with HIV who are enrolled in the OVC program from about 27% to 90% over a 6-month period. This was just the first step, with the ultimate goal being achieving viral suppression. So once enrolled, we would then give OVC services to these children in line with the 4 domains of health, safety, stability, and education, and then help be maintained on treatment, stay adherent to optimize the ART regimens, and making sure that we help in the transition to DTG, and also that they can be able to get MMD prescriptions, and then make sure that these children and their households stick to their schedule for viral load follow-up, and then trying to link everyone who would have missed the follow-up back to treatment so that they can be monitored on time. Next slide. So to achieve this, the program has been in existence since 2013, and this was more like a pivot in the mandate of the program, coming from a program where we provided adherence and retention support to everyone, to a more children and adolescent-centered program. So this meant that we needed to re-engage all the stakeholders so that they understand the mandate of the program and what we were supposed to be doing going forward. So the first thing was working with the Ministry of Health and Social Services in Namibia. So we signed an MOU on them for us to be able to collaborate in recruiting these children and also be able to share data. After that, we trained our CCWs, who are community care workers, on basic HIV in pediatrics, as well as adherence and disclosure counseling in children. After we did that, we then mapped the health facilities in the catchment area to identify mostly the high volume sites. And then we started targeted enrollment of all children less than 17 years old, those who have been lost to follow-up, those who had missed appointments, and children who had high viral load. These were our priority at enrollment, as well as the other children who were doing well on treatment. Next slide. So some of the interventions which we implemented in order to achieve this, we sensitized the key stakeholders so that they understand the role of the community partner, and also help us in the recruitment and enrollment of these children living with HIV in the program, and also form networks for us to be able to refer them for other services which we don't provide as a community partner. After that, we trained our community care workers and district nurses on CQI, and then provided them on-service training through different platforms, including the Ministry of Health run Project ECHO platform. We developed some job aids to help them facilities identify the most vulnerable children and quickly link them to the community program, to our OVC program, so that we can enroll them and provide them services on a regular basis. We had regular meetings to provide feedback on the progress towards our target. And then once clients were enrolled in the program, we developed an electronic system which would send messages to our community care workers and district nurses to notify them if there's any child who has missed follow-up, any child with high viral load who may need to be followed up. And then so at the facilities, to make it easier for the health facility staff to be able to identify which children to link to the program, we came up with a sticker system where the health facility nurses will put a color-coded sticker on the patient care booklets for all those children who have been enrolled in the program and are getting OVC services, and which made it easier for them to quickly pick up the children who they needed to forward to the OVC program for enrollment. So from the baseline, we estimated that in the catchment area, in the 8 regions on 18 districts which we covered, there were around 9,461 children living with HIV who were less than 17 years old. And from the program, we already had about 27% of them enrolled already because of other vulnerabilities they had, not specifically that they were living with HIV. And through the interventions I mentioned earlier on, it's 3 months, we had about 67% of our target, and at 6 months, we were a bit short from what we had envisioned, which is 90%, we had 79%. With regards to viral load, you can go to the next slide, Alpha. With regards to viral load monitoring, at baseline, we didn't really consider the viral load which we had. It was self-reported viral load. We were still working on the collaboration with the Ministry of Health so that we can share data easily. So we disregarded all the information, the data on viral load we had. But as time went on, we realized that at 3 months, 89% of the children had a viral load recorded. And then at 6 months, 90% had a viral load recorded. When it came to viral load suppression, at 3 months, it was a bit low, but again, at 9 months, it was 90%. Viral load, as we know, the impact of the program can take a little bit time to really show when it comes to viral load monitoring. But we are for sure that with time, this will improve and will eventually achieve the 95-95 goals in the children who are living with HIV in Namibia. Thank you.
Thank you so much, Adrian and Project Hope, for that very good presentation. I will move on to Ivan from Mozambique. Ivan, over to you.
Hello, good afternoon, everyone. My name is Ivan Titos, and I'm from Mozambique, and now I'm working in Uganda as a technical director in OVC program funded by USAID. For this presentation, I will try to bring how the Chenge Taiwan project was able to
can people hear Ivan, or we've lost him?
I think we have lost him.
Okay, I think whilst we are waiting for Ivan to
use the clinical data to improve the enrollment of people. Hello,
Ivan. So we lost you a bit. Can you start your presentation again? Thank you.
Hello, can you hear me now?
Yes, we can hear you. Can you restart? Thank you.
Okay. Yeah, I was saying that my presentation goes to our experience that we use or we have it using the clinical information to improve our program. Chenge Taiwan is a 5-year program which is being funded by USAID and is being implemented in Manica province in Mozambique. Next slide, please. Next slide, please. So our focus at the beginning of the program, because it was a time that OVC program also was shifting in terms of orientation or work more with children that are living with HIV. So in our startup, the process was to transition the beneficiaries that we having from 2 OVC programs that were being implemented in the area. One was from World Education Bantwana, FCC, and another one from FHI. So at the time, we, in terms of the number of the beneficiaries that we have transitioned, we were talking about 400.5 children. So our mandate was to ensure that at the end of fiscal year, we really reach the 90% of the children enrolling in our program. So we are working in the 33 health facilities, and the program has the main goal to improve the life of the children by varasuppress. Do they get varasuppress? So at the end of K4, now we're able to reach 81% of enrollment of the project, which for us is a great opportunity to amplify the active role to address pediatric gaps and other social vulnerability HIV in Manica. So we had to develop some strategies so that we can, in a very short time, ensure that we have the 90% as a goal in the program, and ensure that other years we really leverage other interventions. So the first step was to have a conversation, member of understanding with the clinical partner, not just the paper, but also get their commitment and leadership, and have the leadership in this process to work together in periodical base. We address the gaps that we are facing in this coordination. We are talking about in the level of health facilities, but also in the level of the cadres that are operating in community. Another thing, one important thing that I think is now common in all OVC programs, we have to allocate the linking facilitator with the role of identifying and extract the list of HIV positive children, and refer to cascade worker at the community level that do that he has the role of do the enrollment in the households. And other key important strategy from very beginning we assessed to information or patient records of the children, children that are in TX card, to ensure that we have information of them, mainly of the address, so that we can allocate this the cascade workers based on this information, because usually we were just recruiting the cascade workers, but by using this information, we were able to see where it's important to allocate the CCW in the community. And very beginning also of the first quarters, we know that we have different subgroups of OVC that we have to enroll in our program, but for us, we prioritized the children living with HIV, and after the K2 and K3, it was the moment that we included other these beneficiaries in our program. So one of the important things also that we have done we recruited based on TX card. Also, we had to establish active collaboration with community leaders so that they played a key role also in the case management process from identification to the service delivery. Next slide, please. So this is the coordination flow that we established within the health facility. We have first the health facility at where we have the electronic patient track system. We're able to access through this memorandum of understanding where the linkage facilitator had the role of to start the list of the children living with HIV, and also the linkage facilitator in a weekly basis. He interacts with the cascade workers to share the names, and the cascade workers has the role to go to the households and do the enrollment. So when we are moving to other periods, we noticed that the level of enrollment was decreasing, mainly because of some issues that we were having. So we start to see that main challenges were related to the vague information of address of the children. So together with the clinical partner, we decided to during the clinical appointments was the opportunity to also the OVC makes the offer to the families. So some key points are very important in this process that we note. Sometimes clinical data are not okay. So it's important to linkage facilitator collect carefully the personal data of the beneficiaries, and name, age, address, which can influence the enrollment. Also, it's important from very beginning to collect all clinical records of the children, regimes, date of clinic appointment. This also will able to make informed decision in terms of a system, and also update the care plan of the children. Also, it's important to do regular meetings in terms of to give feedback the health facilities. What is the situation of the children that have been referred by clinical partner. Next slide, please. So as we can see in terms of results, these are new customer indicators that we are reporting now. We have OVC offer enrollment. As I said, when we start with around 400 and 400.5 positive children transition from other OVC programs. But with this collaboration, we were able at K1 to offer 26% and enroll 6% of the children. But in K2, we able to make offer of 74% and 84% of enroll. We having 84% of enrollment of the children in our program. So we have these different graphs here because at the beginning we are not able to have the right TX cars. So we were estimating because the TX car was 1 to 90 years old children. But from K3, from our discussion and collaboration, the clinical partner was able to adapt their system and start to give us the right numbers of children, and we're able to do the right analysis. So in K3, in K4, we're able to reach the offer for 92%. And to do enrollment on 93%. So at the end of this fiscal year, we're able to reach 81%. So just to conclude with this, we think that now we are well positioned to give more support to children in terms of parenting, hard literacy, also support and in integrating in optimized regime of the children, and address also the other social needs that the families are facing. So I'm finished for now. Thank you.
Thank you so much, Ivan and Anda, for that presentation. Thank you so much. Before we continue with our Q&A, I have a few questions for our panelists. I'll start off with questions to Project Hope. Yeah, so I have a few questions. So I'd like to congratulate Project Hope for the outstanding results that you presented in your abstract, really remarkable results. Can you tell us more about the role that the OVC case manager played in achieving these results? That's the first question. And would also want you to tell us a bit more about the practical tools that you used to support the OVC case managers in implementing their work. So over to you, Adrian. Thank you.
Okay, thank you, Alpha. Our OVC case managers are practically the drivers of the whole program, from the recruitment to the case management itself, to household visits. They all played the part in making sure that these children we recruited the program actually end up staying in the program. These case managers, we had some of them seconded or stationed at the health facilities so that they can work closely with the clinical staff. So they were a very important part in making sure that the relationship between the clinical partners and the program itself grows to become where it is now, where we can easily share data, where we can easily collaborate on cases, we can case conference and share ideas on how we can improve the services we provide to our clients. So I would say that was the main role of the case managers with regards to this whole recruitment and the continued provision of services as we go forward. The second part of the question, Alpha.
So what kinds of practical tools did you use to support the OVC case manager? Like job aid, training, what sort of practical tools? Thank you.
I would say we developed paper-based tools, we developed electronic tools. I highlighted the stickers earlier on. So with the paper-based tools, these were mainly to help them once you enroll someone into the program, what services do they need for a start, which are clinical? Let's say, do they need a viral load? Do they need to be registered in the high viral load system? We have our own high viral load system where we provide different services from those who are suppressed. With the relationship to electronic systems, we tried to develop tools, reminder tools. This is an electronic system where whenever a client is entered into the system, it actually picks up the date when they are due for their next viral load and what their viral load was, and in other services they may need which are urgent. And whenever these services are due, it sends a reminder to the district nurse and the M&E people on the district level so that they can tell the CCW that, or the case manager, that the client you actually served on this day is due for these services. Can you check if they have received their services? If not, can you remind them and maybe help them get the services at the facilities? With regards to the sticker system, which I alluded to earlier on, this was mainly for helping the district nurses at the facilities to determine which clients have already been enrolled in the OVC program, so that the referral can be easier and they know what type of messaging to provide to the clients as they come in for their regular checkups, their regular follow-ups with the facilities.
Thank you. Thank you so much, Hadrian. Thank you so much. The next question is to TPO Uganda. Carol, I'm very impressed that you were able to increase the percentage of children and adolescents living with HIV that were virally suppressed from 78% in Q1 to 90.3% in Q3. The pairing approach that you developed certainly seems to be successful. Can you talk about any challenges that you experienced as you rolled this pairing approach out?
Thank you so much, Alpha, for that question. I must admit that the pairing approach had a number of challenges. So some of the challenges we had included issues of disclosure, because I talked about the involvement of the community development officers and, pairing the parasocial workers that we have at community level with the social workers. So we realized that we still had beneficiaries that we had on the program where disclosure had not been done. So for such a client, you wouldn't want to pair up a team to come and give them services when they are still dealing with disclosure issues. The other challenge we faced was that at some health facilities, we had challenges of delays in obtaining results for viral load. The bleeding is done, but then the turnaround time of results coming through was one of the other challenges we faced. Then we also had challenges of children that had multiple issues. You have a child on the program who is not suppressing. When you go and assess them, you realize they have insufficient food, they do not have transport to go to the health facilities, they lack a treatment supporter, they live with an elderly caregiver, and maybe there are issues of violence in the household. So you realize that there are a number of challenges to deal with. The last challenge we had was at the side of the facility, we had children that were overrepresented. Every time it was an appointment day for the child, you had the caregivers taking the children. So that was also a challenge on our side. So what did we do, or what have we been doing as an OVC partner? Number one, for children that were overrepresented, we have been ensuring that we do appointment reminders at household level, but also for some of those that live with elderly caregivers, I already mentioned that we've been trying to identify treatment supporters, because we realize we can't rely on those elderly caregivers to be able to support the children. Where we had challenges of disclosure, we agreed and discussed with the health facilities to start supporting the caregivers to disclose to their children. So it is a process. So for some of these children, actually, we did not use the pairing approach because it wouldn't work for a household where disclosure hasn't been done. So what we've been doing as an OVC program is for such households, we continue to do the usual home visits and supporting them one-on-one. Where we had delays in obtaining viral load results, usually we have monthly meetings with the clinical partners, and some of these are the challenges we've been sharing, and we realize that this has actually improved. And the children with multiple challenges, we take a step at a time. You use the pairing approach, but as you also empower the household economically for them to be able to respond to other needs that they have at household level, while you're also addressing the violence that the household has. So those are some of the challenges I can share that we have encountered as we use this approach, and how we have been able to address them. Alpha, did I skip any other question?
I think you touched on it. So from your experience, how do OVC wraparound services and case management help address barriers to HIV testing, linkage to treatment, continuity on treatment, and viral suppression for children and adolescents? Maybe you can just give us a few thoughts on that. Thank you.
So the OVC program comes in really handy to address most of the gaps that we have in terms of testing, adherence, and suppression. Because the OVC partners are usually closer to the community. Like, for example, in our case as Keeping Children Healthy and Safe, we work with a structured community level called the parasocial workers. Now, these people are very closer to the household than the health facility. So what we do is we support in mobilization. Like for HIV testing, we are able to work closely with the health facilities to identify children that are targeted for index testing, and we can easily mobilize these households. We can walk to the households and be able to mobilize them. But I also mentioned that when you look at issues of adherence to treatment, we conduct home visits on a monthly basis. And one of the things we do is adherence counseling at household level, but also treatment reminders. Like, you know, we keep checking and ensuring that the clients we have on the program do not miss their clinic appointments. On the issues of viral load suppression, as I already mentioned, we identify the barriers. The facility does intensive adherence counseling, but we realize that some of the challenges affecting viral suppression can only be handled at household level, for you to understand the family, for you to understand the challenges they have and address those challenges at that level. So we also go ahead and assess, identify the barriers, and we work closely with the family to be able to deal with the challenges they have. We work closely with the local government, the community development officers, to address any challenges. If challenges are around gender-based violence or violence against children or child protection issues, we make sure that these issues are actually addressed. So if the OVC partner is doing their work, actually it becomes easy to achieve the treatment outcomes that we want to see.
Thank you so much, Carol. Thank you so much. So my last questions are to Ivan Anda. It is remarkable that you were able to increase the number of children and adolescents in the project from 426 in Q1 to 3,518 by the end of Q4. That was a huge jump. Can you talk about the process and how those excellent results were achieved in such a short period of time, from 400 to over 3,000? Can you tell us the process that led to that success? Over to you, Ivan.
Thank you. Maybe I will emphasize a point that I made at the beginning of my presentation. As a process, we have this number of children in our program. As the point of the presentation was have good partnership and relationship and rapport with clinical partner, so that the OVC program would assess from very beginning information of HIV children. So this was done before even recruitment of the CCW, the cascade workers in the community, and also was done as an informant way to place the children and make the process of case management until the graduation of the family is easier. So one of the things was to navigate into data of the TX card, looking for address of the children, and from the address of the children also have a structure and the practice of the linkage facilitator have regular meetings with the CCWs to look for the gaps and challenges that they in weekly basis they are facing for the targets that they've given to reach each week or in terms of enrollment of the children in community. So I'm seeing in the comments we use it two pronged approach to enroll children. One, to we be fast in this process, we use the community cascade workers, but also the linkage facilitator. We're using the clinical appointments to offer enrollment, mainly in cases of that CCW were not able to reach the family because of not locating due to wrong address or vague address of those children. So also in Mafele Basin, we were sharing this data with the clinical partner and showing them where was our level, and also was an opportunity today also update their database, because there were other cases that the children, when we are given the name of the children, when we reach the community, they were not having that age of children, but they were adults. So those process of collaborate with clinical, particularly in M&D area, is really critical in the very beginning of the program. Or it's important to, if the program is in the middle, to look careful to these informations. For the children that are really far from the areas that program is performing, what we are now doing is to try to check how many can recruit new and allocate to these areas. So in this way, we are seeing as a path to leverage other OVC service to those families. So this is the critical process is to assess information of clinical partner, every information of the patient, to take informed decision within OVC program.
Wonderful. Thank you so much, Ivan. Thank you so much to Anda for those responses. In the interest of time, I would like to open up for questions to the participants. I've seen a lot of traffic in terms of questions and some answers being provided, but please, now we've opened it up. Please feel free to come through with your questions. And Michael, please, you can also alert us to questions which have not been responded to. Thank you so much.
Sure, Alpha. I've been gathering the questions here. I did notice a few have been answered in the chat. Thank you so much to the panelists who have been active in answering those questions. Some of the questions that were written into the Q&A I've noted as answered as they have come up in the responses to your questions, Alpha. But I do have a few questions here that I would like to share. Some were directed to some of our specific panelists, others may be more generalized. So perhaps in interest of time, I will first ask a question that, or share a question that perhaps could be answered by all of our panelists. So here's a question. It says, did you experience children giving you incorrect personal information, such as incorrect addresses? How did you overcome this? We find that clients choose health facilities far removed from their homes due to stigma. Would anyone like to tackle this question?
To our panelists, please, can one of you respond to that question?
Okay, so I can respond to the question. So we had issues of wrong information and wrong addresses. So the way we handled this is that during enrollment, we worked closely with the facility peers and the counselors, because usually for them, even when people are giving wrong information, they have adequate information on where these people stay. But we also worked with the PLHIV networks in the community that supported us to be able to identify the right addresses of these children. Yeah, so that's what I can be able to say about the question.
Thank you. Any more questions, Michael?
Yes, we have a question here from USAID for the child. Given that the linkage facilitators offer enrollment at facility level, how does the project ensure comprehensive household assessment before enrollment into OVC as a critical case management for OVC comprehensive model?
Okay, thank you. I'll get that. I think I answered it in the chat box as well. At the facilities, it is mainly an entry point where you get consent, where you sell the program for the beneficiaries to understand what the program is all about. And then the follow-up assessment is done at the household so that we have an idea of how the household is like, who is there, what other needs are there. So I would say not any of the assessment is done at the facilities, but it's a place where we get in contact with the clients for follow-up assessments at a later date.
Thank you.
Thank you so much, Dr. Mngwana. I have a question here from Jimin Sontio. How do you handle case worker to household ratio for efficiency of service delivery?
Good question. How do we handle case worker to household ratio, panelists?
Yes, for efficiency of service delivery.
Yeah.
Well, what we did here in Namibia is we classified the health facilities according to the number of ALHIV they have, which is maybe an estimate of the households in that catchment area. And we allocated these community care workers based on the number of clients we expect from each facility so that we don't end up overloading others and while the others are having a fewer target. So that's how we manage the case manager to household ratio.
Thank you. Thank you so much. I know Michael has to drop off now to prepare for the next session. So Michael, thank you so much for managing.
Oh, you're most welcome, Alpha. There's one last question there in the chat. Perhaps this could go to
the chat for us in the slide. 5 minutes to go. So, hello? Okay, so would like to open up. Michael has to leave us. Any more questions from our participants? Questions that you feel have not been answered, please, with 5 minutes to go. If you could just come up with those questions so that our panelists can help us in responding to them. Are there any questions from any of our participants? Please feel free. Are there any outstanding questions? Okay, so I think
there is this. Sorry.
Go ahead, Ivan.
Yeah, there is this question of how to convince the caregivers, parents of confidentiality and safeguard their data information. This is special for those who refuse the consent of data. My thing is that when we are doing the recruitment, it's really important to check the profile and also looking for the cultural values of the communities that we want to work. For example, we have a district named Musuris and Machas actually, that we know that it has a lot of issues related with the masculinity, and the woman has less voice than men. So we want recruiting a young person to be cascade workers in that community, because we already know that there is this problem. So we might look to a profile that we know that it will have acceptance from the community, which is varies from community to community. So it's really important to check the profile of the cascade worker that you are recruiting, so that they are not facing so many challenges in terms of get consent of the family to be part of the program, mainly when we are talking about issues related to information of HIV and also stigma. This was one of this one is one of experience that we had some districts in our program. We noticed that in some areas when we are having we were giving children to young and also women, we see that the level of enrollment of one to other was different. And also in weekly meetings, we were seeing that in terms of reporting, what was key to the ones who were recruiting more was more related to the profile in the contextual aspect of the areas. Thank you.
Thank you so much. There's a question there. I'm not sure if you answered it to Anda. Does each facility have a linkage facilitator, or they are shared?
It depends on the volume of the health facility. It's important to you check what is, because we are working in the Ajuda site health facility. Is what we name that were given by USAID. It's important to you check and also look into your budget, how many you can allocate there. But normally in the health facilities that has more children than others, you might think to have more linkage facilitators there than other health facilities that there are less children.
Mm-hmm.
Thank you.
Thank you. And then there's another question there. Do you face resistance in placing cascade workers at CDC health facilities? I think this question is directed to any of the panelists. Do you face any resistance in placing cascade workers in CDC facilities? And how do you handle that?
Okay, so
Okay, go ahead.
As Project Open Namibia, we didn't face any challenges. They are welcome to more hands coming in to help with the program. So yeah, we never faced any challenges with that.
Thank you.
So in Uganda, we had a few challenges with some CD sites, but what we did is the caseworkers we have are usually people that have interacted and have been working with the health facilities, like, facility peers. So that reduces the resistance because you're not bringing someone new to put them at the health facilities.
Mm-hmm. Thank you. Thank you so much. So folks, our time is up. Thank you so much to our panelists for the exciting discussions that we had. A big thank you to all the participants who managed to join this session, and we encourage that further conversations continue even beyond this session. So a big thank you to all of you. Thank you and bye-bye.
Thank you. Bye-bye.
Bye.
Thank you.
Bye.